Assalamu alaikum. Good morning. First of all, thank you for organizers and society giving me this opportunity to talk to you guys this morning. And thank you, all of you, to be here on the weekend that early. So today, what I'm going to discuss is about peripheral neuropathy. So peripheral neuropathy had other names that we commonly use as interchangeable terms. That includes a distal symmetric neuropathy or peripheral polyneuropathy. So keep that in mind. So with relevant to the topic, I have nothing to disclose. What are the learning objectives? You can see there, I'm going to discuss about the prevalence of neuropathy, common presentations, and identify the common causes for peripheral neuropathy, discuss the utility of laboratory testing for neuropathy, and recognize the therapeutic options, mostly symptomatic. What is the peripheral neuropathy? Peripheral neuropathy is characterized by symmetric numbness, paresthesias, pain, and weakness, which are predominantly involving the distal part of lower first, followed by the upper extremities. It is a debilitating disease. It causes significant effect on the quality of life due to the pain, have a significant financial effect on the society and even on the patients and patient's family, significant morbidity and mortality. What are the epidemiologies? Epidemiologies, if we look on for neuropathy, it's basically variable depending upon the studies that was performed. And mainly the part of the reason is that variability is depending on what the definition of peripheral neuropathy they have used to include the patients in the study. Unfortunately, until about 2012, we do not have a consensus about that. What's the definition of peripheral neuropathy when international peripheral experts sat down in Toronto and they come up with the classification of peripheral neuropathy. And since that, we are using that definition. I'm going to come up with one slide for that. So if we look on epidemiology, as I said, is variable. Its most current prevalence is 0.1 to 3.3. Elderly population have much more prevalence than the younger population. If we look on studies from the Africa and Middle Eastern countries, study prevalence goes about 0.8 to 2.5 per 100 persons. Diabetes is the most common etiology. If we look on the patients and the diabetics that you can see newly diagnosed or non-diabetic, they have a percentage of goes up to 42%. Even a pre-diabetes, it goes up to 12%. Abnormal glucose tolerance test and impaired fasting glucose also have a significant number of patients. As compared to that, the control population have much more less. The incidence, especially if you look on type 2 diabetic, they are much more than type 1. And there are a lot of patients populations, they have basically other risk factors that associated with diabetes. That's the part of reason that type 2 has more prevalence than type 1. With reference to prevalence, given that these higher prevalence and also diabetes have a strong association, you can imagine that right now there are about 400 million people in the world, they are diabetic. So you can imagine how many patients are affected by peripheral neuropathy. And if we take other carbohydrate metabolic disorders, then pre-diabetes patients are have 12 to 13%. And there are about, at this stage, 380 million patients who are pre-diabetic in the world, and that population is going to rise up to 450 million in 2045. As about 10% people in America are diabetic at this stage, and the pre-diabetes, if you include that, that's 1 in 3 people are pre-diabetic. What's the age-specific prevalence? The prevalence goes up as the duration of the neuropathy goes up. That you can see it. If it's newly diagnosed, 8.3. After 10 years, 41.9. And also, look on control, that's only from 2.1 to 5.6. Age, and as I said, in patients more than 80, it goes above the 30% of the prevalence. Females, unfortunately, have more tendency as compared to male. And that's the other reason also that the prevalence of diabetes is, peripheral neuropathy is increasing given the population is aging more. And all. What are the clinical presentations? It has a heterogeneity in presentation, so sometimes it causes more challenge to diagnose. Positive motor symptoms, what we see is a cramp, twitching, myokemia, negative motor symptom, weakness, fatigue, and wasting in the muscles. That's a reference to a motor symptoms. If we look at positive and negative sensory symptoms, positive sensory symptom is pain that can be burning, lancinating, buzzing, tingling, paresthesias. And that's the most common presentation. About 30% population have it. Negative sensory symptoms is a numbness, hypesthesias, gait abnormality due to the ataxia. Autonomic symptoms, you can see early satiety, bloating, constipation, diarrhea, impotence, and orthostatic vital headaches or the lightheadedness, abnormality of sweating can be seen too. Mostly the presentation is with that a positive sensory symptoms. What is the history? I think history is the most important that helps us to diagnose the peripheral neuropathy, and also about 80 to 90% times it can also tell us the etiology. On the history, the most important thing to focus on chronicity, how the symptoms started. Mostly this paresthesias or the positive or negative symptom starts distally in lower extremities with the toes or the ball of toes or the forefoot. Initially, they are episodic, and then it becomes more constant. Evening or night times with the symptoms are a lot more worse as compared to the day when they are busy in the morning. So that typical presentation is chronicity, and as compared to that, subacute onset and hyperacute or acute onset does not fit with peripheral neuropathy. They have other autoimmune or inflammatory etiologies. By staying on this topic, I would say that if somebody had a neuropathy symptoms that just started and is a young or does not fit with the typical presentation for metabolic toxic causes, so it's important to refer them and appropriately in either an acute hospital setting or the ER. What are the other symptoms, other history points that can help is a gradual onset and slow in progression, pace of progression that takes not weeks, it's months and years, and even decades. Monophasic illness versus chronic progressive, that's not a typical feature for neuropathy. Rapid accumulation of pathology, that also suggests either is a central etiology or spinal cord. And stepwise progression also speaks either is underlying another a mononeuropathy compressive or other etiology. What are the anatomical distribution? Mostly is a symmetric, distal, length-dependent, stocking, and glove pattern distribution. Monomelic or low focal distribution does not fit with peripheral neuropathy, and same thing for patchy. If it's a patchy distribution, that means there's another etiology that's mostly either autoimmune, vasculitis, or other post-inflammatory. With reference to nerve fiber involvement, either sensory or motor, and those are the fibers are basically responsible for positive and negative sensory and motor symptoms. Unfortunately, initial presentation is a length-dependent, basically a paresthesias that involves the light touch temperature, that involves the small fiber involvement first. That's mostly gamma fibers and C fibers. Decreased sense of position and vibration, stretch reflexes, difficulty with tandem gait, and positive, that's the signs for large fiber involvement. What is the time that is important if you see a patient with acute onset that the symptom has started from days and weeks, and if there is any other factor that make you to think like there are patients who had a vaccination in the last 2 to 4 weeks, had upper respiratory tract infection, have gastroenteritis, or even surgery or trauma, and it's very important to recognize those risk factors and think that this is acute onset to refer the patient in timely manner either to the ER or to the neurologist for further workup. Subacute, same thing, weeks or months. It's better to refer to the neurologist. If it's a chronic, that goes to months and years, and as I said, decades, and it has a known factor or etiology that can be managed in the office. What is the etiology? If we look on the etiology, you can look on this slide, which I put it there. It's predominantly, you will see, is idiopathic polyneuropathy. The second common cause comes cryptogenic neuropathy, and then followed by toxic and immune-mediated. Hereditary have some role too, but if we look at that other carbohydrate dysmetabolism, that includes impaired glucose tolerance test, a prediabetes, patients with a hemoglobin of 5.8 to 6.4 or less. So these cryptogenic axonal neuropathy, basically the chunk of these patients have those a prediabetes or impaired glucose tolerance tests. So overall, I would say about peripheral neuropathy, close to 65% etiology is diabetic or diabetic-related disorders, as I mentioned. What are the diagnostic tests? American Academy of Neurology recommended, given the cost effectiveness and possible etiology, these tests that you can run it to find the etiology. First, obviously, diabetes or abnormal glucose tolerance tests, vitamin B12 with methylmalonic acid, serum protein electrophoresis, comprehensive metabolic panel, CBC. Rheumatology and thyroid testing have very low yield, but it costs. So in certain circumstances, it's important to do it, especially going back on history. If the patient have history of rheumatological disease, thyroid disease, or any skin disorders, then it's worth to do autoimmune workup. In a history, worth to mention also, the important thing is to consider a comorbidities, patients who have been on chemotherapies or have a history of cancer. That also needs to be considered. There are a number of medications all also responsible for that. We have seen in patients who have been treated with iron replacement, and when their iron replacement have been stopped, they presented with the restless leg syndrome. That I feel personally is very underdiagnosed, a condition that patients for some reason on iron replacement, they stopped and they have a typical restless leg syndrome. If not triad, at least 2 of those features. What about the electrodiagnostic studies? Basically, electrodiagnostic studies only helps us is an extension of physical exam and is a history, basically. It tells us about the anatomical distribution of nerve fiber involved, is it length dependent or not. It tells about the duration, is it acute, subacute, or chronic. It also tells us which fibers are involved. Is it sensory or motor conduction studies? It can assist us basically to find out is it a multifocal, is it distal to proximal, or is it generalized localization, basically. If you ask me, I think they have study done that typical presentation of neuropathy, they have about 260 patients. Only two patients have EMG nerve conduction studies have changed the diagnosis. So in a typical presentation, unfortunately, EMG nerve conduction studies have not much role, but there are certain exceptions that I'm going to come up later on. The autonomic function testing, that you can do it if there's autonomic involved. You have tilt table, Valsalva with cardiogenic adrenergic functions, cardiovagal functions. You can look at those pseudomotor functions, QSOT, TST. TST stands for thermoregulatory sweat test. And the skin biopsy, worth to mention it here for small fiber neuropathy. Indication for EMGs are asymmetric presentation, non-length dependent presentations. Asymmetric presentation speaks that if especially it is asymmetric for after a while, symptoms started, probably another etiology to look for. Motor involvement first, then the sensory, acute or subacute course or onset. And if there are prominent autonomic involvement, that also suggests that EMG can help for that. Mostly the patient with amyloidosis neuropathy, acute neuropathies, including GBS, and even diabetes also have some autonomic involvement. How to confirm? This is I was talking that in 2012, the international consensus was how to confirm, what is the definition of the for peripheral neuropathy. So this is a confirmed neuropathy, abnormal nerve conduction study with symptoms and signs, probable with sign and symptoms, and possible only either sign or symptoms. What's the non-pharmacological treatment, basically? Is a reassurance and discussion of the diagnosis. You wonder about reassurance because patients comes to us to see, they have a lot of concern if they have those symptoms. They're probably Google their symptoms and the Google first bring on terrible things first on the slide than anything else. So that makes them to worry. So reassure them, discuss the diagnosis, educate about the risk factors. Weight loss is very effective in patients who have a metabolic syndrome. As we know that in metabolic syndrome, hypertension, hyperlipidemia, and smoking are independent risk factors. Control of those risk factors and etiology is very early, potentially can help. And before we say that for peripheral neuropathy, if it's established, we say it's a one-way street. Unfortunately, you cannot reverse it once it's fully established. What about the exercise and non-pharmacological? Moderate aerobic exercise for 150 minutes in a week showed a significant increase in number of cutaneous nerve fibers with the skin biopsy and improvement in the neuropathic pain over 2 years. Physical therapy to prevent falls, foot care, and some aspects of early neuropathy. Talking about the foot care, the complications, we don't have a lot of data in other countries, but if you look on England, there are 140 patients who are getting a foot or toe amputation every week due to the diabetic neuropathy complications. That puts in a year about a country of 60 million population, about 8,000 people in a year, 7,500 to 8,000. And this has a significant risk factor, it's morbidity. So if patients who have a foot amputation, their likely mortality in next 5 years is close to a 25 to 50%. And patients who had a foot amputation, their 5-year mortality is much less as compared to breast cancer, prostate cancer, and colon cancer. So you can imagine that if it's untreated, how big impact it will be. So what about the management with the risk factors, basically? You can see it if it's a carbohydrate dysmetabolism. So there's intensive glycemic control that had reduced the risk factor reduction risk about 65% for 5 years during the study. Even after 4 years, those patients showed a 25% reduction as compared to 35% for control. There are other etiologies, as I mentioned, for neuropathy. Let's take it for CMT. There were recent trials with the vitamin C. Unfortunately, they were not effective. And familial amyloid polyneuropathy, there were trials also. Didn't show much benefit, basically. Multiple trials of aldose reductase inhibitor, a large trial of recombinant human nerve growth factor have failed to result in a clinical response. Antioxidant alpha-lipoic acid has reduced, but is a limited, basically, evidence at this point. Vascular endothelial growth factor, A gene, showed a small benefit. What about the symptomatic treatment? So we have 3 big groups of symptomatic treatment: tricyclic antidepressant, amitriptyline, amipramine, and nortriptyline, serotonin, norepinephrine uptake inhibitor, duloxetine, and venlafaxine, and alpha-2 delta ligand agonist, gabapentin, and pregabalin. You can use these basically depending on patients' comorbidities. Patients have a depression, insomnia, mostly tricyclic antidepressants are effective. And also in the depression, basically SNRI are also effective. Thank you very much. That was most of the talk.